Dr. Kevin Flaherty is a professor of pulmonary and critical care medicine at the University of Michigan Health System in Ann Arbor, Michigan. He has a particular interest in interstitial lung disease and was a co-author of the official American Thoracic Society position statement on the evidence-based guidelines for the diagnosis and management of idiopathic pulmonary fibrosis. He is truly at the forefront of this disease state, and we are very fortunate to have him here today.
Thanks, Jan.
Welcome, Kevin.
Thank you very much. It's a pleasure to be here. So what is IPF? So
yeah.
IPF is a very interesting disease. It's a chronic progressive scarring disease of the lung, but for whatever reason, it's just in the lung. So you don't end up with kidney fibrosis or myelofibrosis or skin thickening. If you see those other features, a systemic illness, it's not IPF. You're much more thinking about exposures or an underlying connective tissue disease. So IPF is limited to the lungs by definition, and unfortunately, it tends to progress over time and has a very poor prognosis. If we look at prognosis, we can compare the prognosis of IPF to many different types of cancers, and as you see on the slide, the survival rates for IPF are actually shorter than most types of cancer. So when do we think about idiopathic pulmonary fibrosis? And this is the hard part. We have to kind of always keep it in the back of our mind. Granted, I'm a pulmonologist who specializes in this, so it's easier for me than our audience who's on the front lines and is being assaulted by all sorts of different illnesses.
Right.
But think about ILD in that patient who has a cough and shortness of breath that doesn't pan out to be the more common causes of that. That could be obstructive lung disease or cardiac disease. All those things are very common and need to be evaluated. But if they come up negative, it could be interstitial disease. There are some risk factors: smoking, older age. In fact, some people think that IPF may be an abnormal aging type of disease. It's more common in men than in women. Certain environmental exposures can be associated with the development of pulmonary fibrosis. One possibility is reflux disease. Could chronic gastroesophageal reflux disease actually get into the lungs and be a nidus for injury that leads over time to fibrosis? So there are lots of risk factors that may make us think about IPF, but you can also see IPF without any of these risk factors. So they aren't absolutely necessary to be positive or to be present.
So just going back, realizing all these things, so an older age male who often is a former, not current smoker, with or without GERD, on some anti-GERD regimen, has ill-explained crackles in the bases, an abnormal chest x-ray, and a restrictive pattern on PFTs. I mean, this is the blue light Kmart light that's going off.
Blue light special.
Yeah, the blue light special, because there's something unusual going on here, and that's what we're going to continue to pursue to make this a diagnosis that primary care can feel comfortable with.
Yes, absolutely.
Yeah.